figure out where he was. He came in 2 hours late, and when he finally came in, like, where have you been? And he said, this one required much prayer. And so he said he had been
off
praying all morning, and I
Which
thought
probably was quite accurate.
turned out great. In fact, that was when he came up with the idea for the Dacron sleeve, because mine had poked through and he was trying to figure out a solution.
Yeah.
And so that's when he started doing the sleeve around the end of the spring.
Hello and welcome back to Aronowitzland. Today's video is about facial paralysis. Facial paralysis is a relatively unusual problem, but not rare. And it involves the facial nerve. It's a nerve that comes out directly from the brain through the skull and into the face. It splits into 5 branches here, just in front of the ear. It primarily provides innervation or control of the muscles of facial expression. So all the smile and grimacing and sneering and normal muscles that we use on our face to let others know how we're feeling and express our emotions, those muscles are paralyzed by loss of the facial nerve. There are a couple of other things that the facial nerve controls as well, but the main problem that people have when they lose that nerve is inability to control the muscles of facial expression. It causes a lot of functional problems, one of which is that the eye is too open because the closure is affected by the paralysis. And also it causes a lot of problems functioning in society because the appearance is typically very asymmetric and disfigured looking, and others who don't know how to process the difference in one side of the face versus another don't really know how to react to that individual. So without further ado, I will let our patient describe the problem herself. This patient is a lovely woman who's very, very generous in allowing us to share her story. I'm going to show you her interview, include Dr. Robert Levine, a longtime oculoplastic surgeon who's done a lot of groundbreaking work in this field, and I've had the pleasure and privilege of working with for many, many years. And then I'll catch you on the back end. Okay, so thanks for agreeing to share your story with everyone else. Can you tell us who you are, a little bit about yourself, and then about what happened to you?
Sure. My name is Jodi Brown, and I am wife, mother, 4 kids, professional speaker and author. And about 15 years ago, I had a brain tumor between the end of my ear canal and wrapped around my brainstem. And in the process of removing that tumor, it left my face paralyzed. I had a spinal fluid leak. I lost my hearing, had all sorts of fun complications. But the one that has lasted the longest are the effects of facial paralysis. So in the last 15 years, I have undergone, I think we're at 17 surgeries now to try to fix all of the complications and side effects.
Why people with an acoustic neuroma, which is a type of tumor you had, why they have problems with the face, because it's not in the brain. And do you want to tell us a little bit about why this is a very common problem?
Sure. So in the process of removal, because of the nerves that are all right there, I had issues with my 5th, 7th, and 8th cranial nerves, and each of those cranial nerves are related to a different part of functionality. And when you hit 7th and 8th cranial nerves, that's when you start to have problems with different parts of your face. And so depending on where the tumor is and what the situation is in taking it out, you can end up having facial palsy, facial paralysis. When you have facial paralysis, it's usually one-sided because the tumor is on one side and they take it out. And that then makes it so you don't have control over anything on that side of your face. So no controlling the food and fluids in your mouth. I used to drool and have things drip out of my mouth all of the time. Very difficult to eat and to drink. Can't open and close your eyes normally. And it's a little different from case to case depending on what the exact circumstances are. For me, my eye just stayed in a permanently wide open position and I couldn't close it. I also don't produce very many tears. I only produce about 3 tears per minute, and the drain doesn't work. And so when anything accumulates, it just all accumulates right there in the eye. And so in a course of trying to alleviate as many of these issues as possible, I've undergone a series of different procedures. Most of them have involved my eye.
So why does the eye stay open too much if you have a paralysis?
Because the eye stays open because the muscle that closes the eye no longer works. That's where the paralysis comes from.
That's the orbicularis, the one that orbits or goes around the eyeball.
I'll take your word for it that that's the name for it. But yes, so when that muscle stops working, then you are no longer able to close your eye. And so my eye was very big and wide open, always causing problems. I have had a spring in my eyelid for 14 years. I wore an eye patch on and off for the better part of a year to 2 years as we were trying to figure out how to manage it. So the initial solution was a gold weight. But the size that we would need of a gold weight for gravity to do its job and keep it closed was much too large for me and my body size and for the nature of my paralysis. And so after having a gold weight for about a year, my neuro ENT recommended that I come to sunny Southern California to meet with Dr. Robert Levine to have a palpebral spring implanted into my eyelid. So my first spring was put in 14 years ago. The way that a spring works is it functions very much like a safety pin. It's got the top part, the little spring in the corner, and then it comes over. And that is attached to the top bone right here. This corner of the spring comes over and then it goes across the middle of the eyelid and is implanted into the muscle. So that when the eye relaxes a little bit, it actually helps to close the eye. So it gives you a little bit of, hopefully a lot of closure, but it depends on how well everything's working and how well it's implanted. I have had great success, far more success with the spring than I ever had with the gold weight.
So the spring is quite a lengthy operation and you're awake part of the time. Why would you need to be awake?
No one likes to be awake during surgery, let's face it, but you have to be awake because they have to see if it's implanted in the right place so that they know if you're getting the kind of closure that you need, because they want you to have as much and as tight closure as possible for functionality purposes, but also to protect the eye. And so in the course of having the spring implanted, they have to figure out if it's in the right place, and also they need to make sure that it is the curvature, that they've got it fixed so that it fits the curvature of your eye, because they want it to have a nice tight fit and not have any parts that will be able to come loose or break through. If it's created and fitted appropriately, it should last for years and years and gives you much greater closure than you could have otherwise. This particular spring I have had for 10 years. However, this is my second spring. The first one only lasted a few years and it started to move out of place, and so we came and had to have it surgically, not replaced, but adjusted and put into a better location. In the second round of having a spring, Dr. Levine was very, very intentional and methodical and actually came up with kind of a new solution so that not only when he implanted the spring did he put it in the right spot for closure, but he also put it inside of a little sleeve so that it would better protect the eye and not have as great of likelihood to poke through the eyelid when it did wear out. And if you think about the fact that you have up to 14,000 blinks in any given day, and that is working on repeat, it is simply is going to wear out. So I'm very fortunate that I got 10 great years out of the spring, And now we are going to replace that spring and do a little packing of some fat around my eye to help fill in some of the hollowness in my face that has naturally occurred over the course of 15 years of paralysis.
Dr. Levine, can you explain a little bit to us about how you began doing palpebral springs and where your interest came from in that operation?
When I was a chief resident at Bellevue Hospital at the NYU Medical Center, Professor Mauro Fascia, who came up with the idea of putting a little wire spring in an eyelid to make it blink again, taught us about his procedure. And as it turned out, I had a patient who needed that operation and did the first one at Bellevue Hospital way back when. When I came out to California, I was a Heed Fellow at the Doheny Foundation at the time. I had a conversation in the doctor's lounge with Dr. Bill House, who had pioneered the new approach at that time to acoustic tumor surgery, as a result of which the morbidity, which had been around 15% or higher, went down to nearly zero, making LA a mecca for acoustic tumor surgery. And so Dr. House and Dr. Hitzelberger, his neurosurgical colleague, were doing many, many cases on a routine basis, day in and day out. And he said to me, you know, have you ever heard about the spring operation that was invented in France? I said, actually, I did one when I was chief resident. He said, well, you better start doing them here because we're having a terrible time managing the eye complications in our acoustic tumor patients. We published the first 22 cases in the eye literature in the American Journal of Ophthalmology. That was authored by myself, Dr. House, and Dr. Hitzelberger. And now, more than 2,000 springs later, still doing them. It turns out that of all the things that have been thought up over the years to try to manage that very difficult problem, the spring has been the best. Gold weights work if you're sitting up. Gold weights don't work at all if you're lying down. So you have a part-time solution and not a full-time solution, even with a successful so-called gold weight or platinum chain operation, since they're gravity dependent. The spring works in all positions, and so is a much better solution.
So, what kind of problems do you have functionally from having the eye open too much? It would seem like it would be pretty simple to wear a patch or to tape the eye.
It might seem like those are simple or good solutions, but they're not. It's really tricky because if you think about it, when you think about the number of times a day that you blink, upwards of 14,000 times, you are constantly, that means your eye is getting lubricated, it's being protected, you're getting that closure. When your eye is open all the time, you are a target. The wind blows and something gets in your eye and you can't protect it. Anything happens and there are things that are accumulating in your eye, there's dust, there's debris, it becomes uncomfortable, it becomes painful, then you have also the chance that something's gonna scratch your eye, your cornea gets damaged, and it really is quite an uncomfortable situation. I have tried every method of taping on the planet, I think, and it's just not a great solution because, especially in my case where my eye wanted to stay in the open position, that meant that after some period of time, whatever kind of tape you had on, the eye would still start to open. And I'd wake up in the middle of the night and I have the tape over my eye, but my eye is open underneath. With a patch helps because it takes the pressure off your eye from having to function. And so it does help a little bit with a dry eye. It helps a little bit with the protection. But then you also have, there's quite a bit of stigma. And not everyone is very nice about it, but it also does limit your perception, your depth perception, and it still doesn't solve the underlying problem. So I do still use a patch from time to time when my eye is exhausted and when I just don't have any other solutions. Sometimes I'll still pop a patch on top of there just to give it a little bit of a break, because if it can't get the closure it needs, or if there's some other irritation, sometimes just giving the eye a break will help.
Dr. Levine, do you want to comment on measures that can be taken to protect the eye when there is excess opening, such as in facial paralysis.
Another device that's very useful is a moisture chamber, which is basically a one-sided goggle with a little foam around it, and that creates a moist space.
Is that something that a patient would wear during the day or only when they're asleep?
Primarily for sleep, but it can wear it during the day as a temporary measure. It's not easy to deal with device in a lot of circumstances, in that you can't fit glasses over it so easily if you're wearing glasses, unless you use a anti-fog solution on the inside, because it's moist, it's going to fog up.
Also use a contact lens. Do you want to tell us about that?
Yeah, so the contact lens is a adjunctive device that we can use if you have a reasonable amount of closure. But even with a 24-hour lens that can be put in and left in for a prolonged period of time because it has a good oxygen transmission, those lenses tend to dry out and then pop out of the eye unless there's some reasonable amount of closure and blinking to begin with. So in somebody who's got a weakness but some degree of closure, that's a very good thing. In somebody who's already got even good closure but a dry eye, because the basic pathology has also affected the tear system. By that I mean if you have a brain tumor like an acoustic tumor located such that it also involves the branches to the tear system, the eye produces zero tears, and so that's its own issue.
I have used every one of the options that Dr. Levine has mentioned. I had the moisture chamber in the hospital. That is effective to a certain point, and nowadays there's also moisture chamber sunglasses that you can buy that have a protective covering in the outside so that they protect you a little bit from the outside wind and things getting in, any kind of debris getting in. Those I used that for a number of years. They did finally wear out, but there are options out there that will help. But with all of these different things, I would say they're all temporary. Until you have something like a spring that can actually provide you with true functionality, all of the others are like Band-Aid fixes. But really you need something that's going to give you the functionality that will help you be able to live your day-to-day life without the constant pressure and hassle and frustration of realizing every moment of every day that you've got something wrong with you. There have been many, many times in the last dozen plus years where I've had great days, gone through, lived totally normal life without having to think about the fact that my face was paralyzed, because I've had solutions that have really worked for me and my family, and that is the best solution that you can possibly have.
Well, I hope you enjoyed that interview with Jodi. She's really a very special person, and really shows you how when life gives you lemons, you can make lemonade. I hope it gives you a little insight into the challenges that our facial paralysis patients face, and why doctors like Dr. Levine and myself and many others are very dedicated to trying to help people that suffer from this malady. There are many causes of facial paralysis. Many people have a benign brain tumor, an acoustic neuroma like Jodi, but many others have a Bell's palsy that just didn't get better like 80 or 90% of them do. Some people have trauma from surgery or trauma from other accidents, that sort of thing. There's a wide variety of causes, but the problems that people face are all very similar. They're social, in facing the stigma of not being able to properly express your emotions on your face, as well as the lack of understanding of the public about what's going on with this face that looks really distorted. And then there are a host of functional problems as well. The surgery itself, the spring and other operations for this problem we'll deal with in a second video, but I wanted to make this one just about Jodi so that you could have some insight into why this is a very compelling problem. So Thanks so much to Jodi for sharing her story, and thanks to you for watching.